I'd first like to thank Professors Yakub and Bono for inviting me to give this talk. So to start with, I have no financial relationship with Radi San Judo Volcano. Our current research is funded by the Magdi Yakub Heart Foundation. Now, Professor Senior has kindly set the scene for appreciating the prognostic importance of microvascular function in patients with acute coronary syndromes. But I'll show this extra slide from Dr. Gibson's group back in 2000, where he looked at patients presenting with acute myocardial infarction, over 700 patients. They assessed microvascular function using TIMI blush score, and they looked at mortality after 30 days and found that patients with normal epicardial flow compared to those with abnormal epicardial flow, no surprise there, those with abnormal epicardial flow had higher mortality rates. But the interesting subgroup are those two in the middle, with, on the left-hand side, those with normal epicardial flow, but with microvascular dysfunction having equal mortality to those with abnormal epicardial flow. Now, those with both components being abnormal had the worst survival. So this has set the scene for trying to come up with different tools to evaluate the microcirculation invasively, starting early on in the late 80s with TIMI flow grade, TIMI frame count, TIMI myocardial perfusion grade or the blush score, Doppler-based techniques, and lately the index of microcirculatory resistance. Now with TIMI flow grade, there are 3 grades. 0 is no flow, 1 there's some penetration of contrast beyond the occlusion, but the distal bed does not fill. TIMI grade 2 dye fills the entire vessel, but is delayed compared to the normal vessel, and TIMI 3 represents normal flow. Now there are limitations. It's a qualitative tool. It's not specific to the microcirculation, and we mostly use it to evaluate epicardial stenosis. Further down the line, the TIMI frame count came up, and it was essentially focuses on the number of frames required for the dye to reach a standardized distal landmark. It is corrected for longer LEDs. It's simple, semi-quantitative, but again, it's not specific to the microcirculation and is affected by the resting hemodynamics. Another tool was the TIMI myocardial perfusion grade with 4 grades again, 0 and 1 representing severe microvascular dysfunction. 0 is no blush in the distribution of the vessel. 1, then staining with blush persisting on the next injection. 2, dye strongly present but gone before the next injection. And 3 is the normal finding with dye mildly present but rapidly washing out by the end of the injection. Now it's easy to obtain. It is specific to the microcirculation. It has been shown to be predictive of clinical outcomes in large studies, but it remains to be qualitative. There is significant inter-observer variability, and most of these studies relied on core labs to assess the results, and in small studies, results were quite mixed. Doppler-based technique started with Doppler deceleration time, and that was, they used to look at the deceleration time of diastolic flow, diastolic deceleration time, with steep deceleration times or steep slopes representing severe microvascular dysfunction, especially if it is associated with systolic reversal. I have not used this technique, but what we hear is it was difficult to acquire clear signals, and there are no clear cutoff values mentioned in the literature. This has led to the development of coronary flow reserve using Doppler techniques, and this is a combo wire with both pressure and Doppler sensors. And coronary flow reserve, as Dr. Senior was mentioning, is the ratio of basal coronary flow at maximal hyperemia coronary blood flow at maximal hyperemia to basal coronary blood flow. Now, the drawbacks of this particular technique, it needs a specific platform, a combo wire. It is not specific to the microcirculation, as with all CFR measurements, and it is affected by loading conditions, contractility, and heart rate. Now, this all led to the development of a new score or a new index called the Index of Microcirculatory Resistance, and it's readily available in any Cath-lab which has an FFR platform, essentially. It's simple, specific to the microcirculation, quantitative, reproducible, and predictive of outcomes. Now, just to go through some physiologic principles before going specifically to IMR. Within the coronary bed, pressure along the coronary bed is quite the same from proximal to the distal bed. Flow, on the other hand, diminishes as you move distally towards the apex, and the diameter of blood vessels decreases in proportion to the myocardial mass being supplied. On the other hand, microcirculation, the resistance offered by the microcirculation, essentially the arterioles, are increasing gradually as we go along. Now, this allows the coronary circulation to have a strict autoregulatory mechanism where the coronary blood flow is maintained more or less persistent and at a quite steady state, regardless of the coronary perfusion pressure. This obviously is within a specific range. If pressure falls below or above that, the autoregulatory mechanism becomes faulty. With maximal hyperemia, this again is just the same principle. Within the autoregulatory range, you have stable coronary blood flow, regardless of the coronary perfusion pressure. Now, maximal hyperemia diminishes the resistance offered by the small arterioles, and it allows for the flow to increase in a linear and progressive fashion with the increase in perfusion pressure. To achieve maximal hyperemia, it essentially depends on adenosine. Papaverine had been used. Other agents have been used, but mostly adenosine nowadays. And with microvascular resistance calculations, we need to establish steady hyperemia through IV infusions. Nitrates are given, on the other hand, to make sure that the epicardial vessels are not vasospastic. Now, this led Dr. Fian's group in Stanford to come up with this index in 2003. They studied microvascular function in 9 pigs and defined IMR as the minimum achievable microvascular resistance during maximal hyperemia. Flow was measured in those pigs using flow sensors. Microvascular dysfunction was induced by injecting or embolizing microspheres, and they calculated microvascular resistance afterwards, both true microvascular resistance and via IMR. And they found good correlation between IMR and true microvascular resistance. They also found that this relationship is not affected by the presence or absence of induced epicardial coronary stenosis. Now, IMR, to go through the background, we use the RADI platform, which is present in every Cath-lab performing FFR measurements. The wire itself, besides having a distal pressure sensor at the junction of the radio-opaque and the radiolucent parts, also has a distal thermistor. The shaft of the wire can act as a proximal thermistor, and by injecting 3 cc's of room temperature saline, you can draw a thermodilution curve, and from that, the flow can be derived. Using the well-known formula, 1 over mean transit time, and IMR becomes distal pressure measured via the distal sensor over 1 over mean transit time, and we correct the formula. So IMR is the distal pressure multiplied by the mean transit time, importantly at maximal hyperemia. Now, the setup is, again, the RADI platform, special software that you need to upload to the device, and a normal guiding catheter with a guide wire usually placed in the distal 2/3 of the vessel, 7 to 8 centimeters to allow for a proper mean transit time of the cold saline. Now, 3 injections are made at rest, and after inducing maximal hyperemia, you have 3 basal measurements here, 3 basal measurements here, shown in the blue lines, and 3 measurements after inducing hyperemia, shown in the yellow lines here. And the device automatically calculates coronary flow reserve, index of microcirculatory resistance, and FFR. That was a patient with normal coronaries, so FFR is 0.99. Now, one of the limitations of CFR was being vulnerable to changes in various hemodynamics. So this is a single patient. We see the baseline measurements with FFR being 0.85, CFR 4.9, and IMR calculated at 27. Now, after pacing at 110, we see that CFR drops to 3.9, FFR and IMR remain unchanged. Same patient after injecting nitroprusside, and again, IMR remains unchanged, so does FFR, but CFR has paradoxically risen to 5.2. The same patient after dobutamine to increase contractility, and FFR unchanged, IMR unchanged, CFR dropped to 2.8. Now, we do not have, our primary PCI program has just started in S1, so we do not have any data on IMR measurements in patients with acute STEMI. However, we have a large ongoing hypertrophic cardiomyopathy registry that we are testing the microvascular dysfunction pre and post left ventricular myectomy with the hypothesis that besides inducing LV remodeling, LV myectomy, extended septal myectomy, might actually induce remodeling of the microcirculation as well. So in this patient, 51-year-old male with hypertrophic cardiomyopathy and a predominant presenting symptom of chest pain. We can see the slow flow in the LAD, septal perforators are being squeezed during systole, and somewhat to and fro movement in the middle portion of the LAD. Now, IMR measurement, no surprise, we see IMR here at 71. Now, one thing I forgot to mention is the normal cutoff value for IMR is between 22 and 25. The thermal dilution curves as well look pretty awkward, but if you look closely, they have dual peaks, which probably represent the cold saline moving back and forth with the motion you see, with the dye motion you see in the LAD. Now, one other thing that people are looking for is an index or a score that can predict clinical outcomes. So this study by Dr. Ferian's group, again at Stanford, looked at 29 patients undergoing primary PCI and measured peak CK over the ensuing 48 hours. Those patients with IMR values below 32 had peak CK of 1,200 almost, and almost threefolds in the subgroup of patients with IMRs above 32. Now, they have not measured troponin or CKMB, but that was taken as some proof that higher IMR values after primary PCI can reflect the size of the infarct. Now, this is the same group of patients after 3 months, and they studied wall motion score in the two subgroups again. Patients with low IMR values tended to have improved wall motion scores after 3 months, as opposed to those with IMR values above 32, which showed more or less similar left ventricular function after 3 months. Now, that's another study from Glasgow, and they studied 57 patients 2 days after primary PCI for NTS STEMI, and they looked at peak troponin I 2 days after primary PCI and found reasonably good correlation with IMR values. So this has stimulated coming up with a two-compartment model in patients with acute coronary syndrome. Rather than focusing on the epicardial compartment, we now believe that one should look at both the epicardial and microvascular compartment, with FFR being the tool to evaluate the epicardial compartment on its own, and IMR being specific to the microcirculation. So there are, of course, limitations to IMR. It's an invasive tool. Reproducibility might be an issue if there are significant differences between the sensor position and follow-up studies, but 1 centimeter here or there is not really a big issue. Now, the presence of severe epicardial stenosis is another issue that should be accounted for, and we need to account for collateral flow. And with that, we need to calculate the coronary wedge pressure and account for collateral flow before making our final calculations. Now, one other factor that I do not really know How it affects the measurements are myocardial bridges. With bridges, the distal perfusion pressure paradoxically rises during systole because of the squeezing of the distal compartment of the vessel. On the other hand, flow diminishes to some extent. Now, we know that using FFR, we depend on the diastolic FFR component to evaluate the severity of myocardial bridges. I am not aware of any correction or any means to correct IMR values in myocardial bridges. So the most difficult part is what is the clinical application of all of this? And being mostly clinicians around, I'm sure everyone will be asking, why go through the hassle of evaluating microvascular function if we cannot do something about it? Now, this is being studied, and this is a paper from Turkey in 2007, and it looked at intracoronary streptokinase, a low dose of 250,000 during primary PCI in patients who continued to show high microvascular resistance after correcting the epicardial lesion. Now, the study showed that infusion, and the hypothesis was that streptokinase might combat in situ thrombosis happening in the distal bed. Now, the study did show that IMR values improved. However, this was not translated into clinical outcomes. There are ongoing studies in different departments around the world who are looking at the value of 2B3A inhibitors in patients with high IMR values. They're studying the role of serotonin, paclitaxel. Some are trying intracoronary adenosine at very high doses, and steroids. We remain to see the results of that. Thank you.